Hi, this is Dr. Gulani. I've done numerous teaching videos for all of you patients and have been teaching and sharing my work with eye surgeons all over the world for decades. It's my privilege to help radial keratotomy patients, and many of those patients today flew out back home, and I promised them that I will share today in this teaching video what skills are required for an eye surgeon to dedicate themselves to help radial keratotomy patients, because your eyes are not normal. The optics are not normal. It requires in-depth study, evaluation, and different levels of skills to be used to take you to your best vision outcomes, no matter how complex you are. So let's learn. So here we are with this eye model, which is a cut through the eye, your cornea, your lens, your iris. Even though there are many techniques I will divide that into very basics so we can understand what it is that required in an RKI, all right? So for our discussion's sake today, we'll focus on just two structures in the eye, just two. The cornea, which is where you had your RK. Remember all these cuts, radial keratotomy, radial cuts, and these cuts are at least 90 to 95% deep, therefore they are permanent. We'll come to that in a minute. Also your lens in the eye, which gets cloudy with age. Having seen RK patients and helped RK patients for decades, right here at our institute, and they come here from all over the world, different cultures, different severities, different surgical problems. All of them, I can say today, at this age and time in 2025, will have cloudiness of the lens. Cataract, by definition, is the cloudiness and the hardening of your natural lens, which was clear and soft when you were young. Because most of the radial keratotomies were done in the late 70s, 80s, and early 90s, most people who had it are now in their late 50s and 60s and 70s and 80s as far as age is concerned. So it doesn't matter if your cataract is early or ripe, all those words that I don't like, mature. The fact that you have a cloudy lens, it is one more element affecting your vision, despite your radial keratotomy cornea. So to me, the most important skill that a radial keratotomy surgeon or a surgeon who wants to help radial keratotomy eyes should have, the most important skill is the cataract surgery, right here. It's very important because anything else besides that done takes you in a further wrong direction. So remember, the complexity of your eyes and radial keratotomy is not only the cornea which has been cut, but how it has been cut. Radial keratotomy cuts, sometimes astigmatic cuts with it, ectasia, bulging of the cornea, scars going on, associated dry eyes, pathologies like high pressure glaucoma sometimes. There might be retinal scenarios. More importantly, you may have cataract. Nearly all of you will have cataract by this age and time. Then the pupil, is it dilating well or not? You may have fused dystrophy with it. So all of these are issues that must be looked for. If anyone in your eye takes your radial keratotomy cornea and performs any corneal surgery planning vision short term without thinking long term, that takes you further away from your target because you're already poorly measurable, plus you're fluctuating. So imagine there's no target. How do we know what power lens to put in your eye? Cataract surgery is your final surgery because of age and time. So we have to plan to get there intelligently and safely. So any surgery done besides that lens-based surgery on your cornea takes you even further away from your target and less predictable. So your cataract surgery then becomes a nightmare of measurability and takes you backward. So all these are important concepts. What to do when? It's called GPS in my teaching, correct? You should know. Cannot go sideways and then land up in a dead end. You have to plan it so you know that you're going north, and staged and how you do it. So now let's figure out what's going on. You had radial keratotomy, which is cuts in your anterior cornea going right up to nearly 90% depth inside the cornea. And you have various kinds I've treated. I've corrected patients from not only 4 cuts, but 12, 16, 30, even 40, 45 cut radial keratotomy eyes, and they're all done well. Again, there is no guarantee for outcome. All of your eyes are complex, uniquely disturbed, but it is worth the fight, and that's why I've been sharing our patients over the decades, their entire journeys from the time they arrive to go to surgery, coming out of surgery, years after surgery, flying back for their second eye, and again that whole journey on our YouTube channel, Gulani Vision. So go there, see the stories so I can inspire everybody to fight for y'all. All right? Now, so radial keratotomy in your cornea. So what are the skills the surgeon requires? The first skill I said is cataract part. Very important because majority of you have a cloudy lens. It doesn't matter how cloudy it is. Please understand this factor. Doesn't matter it's early cataract, late cataract, mature cataract, not so right. No, use that cloudy lens as an excuse to correct one more factor that is affecting your vision despite your damaged cornea. Clear here? So, most of these patients need a cataract surgery. Lensoplastique is my approach that I've honed over decades to take cataract surgery to a level that addresses patients with irregular and damaged cornea. Again, remember, we don't advertise, there is no schmoozing around here, no deals, nothing, just a desire to help y'all. None of you are supposed to come to me by some verbiage or some words. That's why we don't advertise. All these techniques that I've defined, laser plastique, which is the next level of laser vision surgery on irregular corneas without cutting, lensoplastique, a level of cataract surgery through irregular corneas, corneoplastique, rehabilitating your corneas without transplant elegantly. All these are specialties that I've created for my colleagues in our profession to create a specialty for them to address things with least interventional surgical artistry. None of this is for patients. For patients, you're coming here for a vision recipe, for a plan to fix your problem, all right? So, a surgeon who wants to help y'all must have the following skills. One, the ability to do laser plastique on your cornea to correct the irregular and extremely flattened and highly astigmatic cornea from radial keratotomy with laser plastique. Also, how to address the scars of radial keratotomy and then the crisscrossing of astigmatic cuts or hexagonal cuts with RK that you'll have. In some cases, people have wrongly done LASIK on RK, which I don't like. Why? Think of radial keratotomy as a cake cut in 8 pieces. Let's say 8 pieces now on a plate. At least the pieces are together. Now you take a knife and you go across, you dislodge the piece. So more instability, more dry eyes, and more changes in fluctuation when you do deep LASIK and RK eyes. So I don't like LASIK on RK eyes. Surface laser technique like laser plastic, specially honed for these cases. So that is a skill that must be absolutely in the surgeon's tool bag. Cataract surgery, lensoplastique, what does that mean? Despite the 30-40 cuts that I go through, and because patients who come here are extremely severe in their problems, but yet even 4 cuts can be worse. Remember what I've taught you all before. Even a 4-cut cornea of radial keratotomy, which is irregularly cut and intersecting RK cuts. Let's for example, look at a cornea here. Let's say this cornea right here. Here we go. Let's say I'll draw it here for you. Let's say this cornea has RK. All right. Now, if I take this cornea, and even if it's just 4 cuts, but the cuts are irregular, and cut with astigmatic cuts across, this is more difficult to do than a patient who has 16 cuts. You're getting my point. And similarly, I've done a patient even with 40 cuts who came in here who reached 20/20, but the cuts were beautifully done, perfectly straight, absolutely aligned, not intersecting each other. So it's with a beautifully measurable and optically clear cornea. You're getting me now. So the number of cuts don't matter, how irregular it is matters. So the first skill the surgeon must have is the cataract techniques that they must know how to enter an RK cornea with all these cuts without damaging the cornea, without taking too many stitches here, without hurting the cataract area, and with the confidence to put in a lens in the bag after removing these hard cataracts. And most lenses that I use in these cases are high astigmatism, meaning one of the most difficult premium lenses you can use in these cases are the high toric lenses, meaning high astigmatism. Because not only do you have to be right in the power, which is already a challenge. Why is that a challenge? Because RKI is very difficult to measure the lens power you need. Plus you fluctuate, so you're changing. So despite that, the challenge taken should be the lens has to be of the correct power and on the correct axis to correct astigmatism. So imagine the challenge when using a high toric lens. Not only does it have to be exactly of the correct power, it also has to have a correct axis, let's say 20 degrees. You cannot make a mistake. So it has to be very accurate. So that's the level of skills required. Plus this surgery, the way we do it, without having you severely, completely out, anesthesia, literally painless the way we've been doing it. And that's why I keep showing these videos to inspire our colleagues and patients. So cataract surgery skill, number 1. Laser surgery skills, number 2. Next, if the cornea is very badly damaged and scarred and has gone down to very thin cornea, you can do a lamellar graft technique. So the surgeon must know how to do a lamellar graft. What is that? Let's again draw that. In your cornea, even though all these cuts are there, I take my uniquely designed tool and I split this cornea and remove this dirty, bad cornea from your arcade and damage. And then I will put a donor graft on top of this. A very elegant surgery, and I still haven't entered your eye. I haven't done a full transplant that people do, and that long rehabilitation, poor vision, 16 stitches, rejections, none of that. And this cornea, as you can understand now, I have now split it into two, correct? And put in a thicker donor graft on top. So now I've made you thicker, clearer, the cuts are gone, and I can now work with this with laser vision or lens-based surgery. So that's another skill needed, corneal lamellar surgery. 3. Patients with RK, many of them come to me, they have RK. They also have Fuchs dystrophy of the cornea behind. That's the underlying layer here, which keeps the cornea clear. So the skills of using a modified DSEC or DMEC technique that I do, where I remove this bad layer and I replace it with a fresh donor of just that layer and correct the Fuchs dystrophy. So these skills are vital for a surgeon at the corneal level. Laser, lamellar graft, and the DSEC, DMEC techniques for the Fuchs. Let's go deeper into the eye. The iris in many cases could be damaged from whatever reason, either RK or someone did surgery, your ability to arrange the iris properly. The colored part of your eye and the pupil, very important. Sometimes the pupils don't dilate. Many men over 60, 70 also taking Flomax, which is a medication for the prostate, inhibits the dilation of the pupil. Now imagine 70-year-old patient with 20, 30 cuts, you have to go through, do the very hard cataract, and you can't see because the pupil's not dilated. So you should have the skills to open up the pupil, the skills to close the pupil, very important. Then you go to the cataract part like we discussed, right? So if you look at all this, your ability to also remove the wrong lenses. If some surgeon has put in a lens that's incorrect, you can remove the lens without damaging the eye. Be able to insert a new lens in the same bag elegantly through the cuts. Very, very important. So let's summarize what skills are needed. I've done a lot of talks for you all, a lot of teachings for you all. This is mostly for patients, but done it for doctors many times, but this is for you. I was just showing one of our most complex cases in the London meeting at the European Congress, and also at the LA meeting in Los Angeles. I explained how to correct complex eyes like these. The biggest thing is the surgeon's attitude and commitment. Has to be focused to helping. So now let's go back. One more layer, very, very important, I told you I must discuss with you, is the tears. Many RK patients, especially women, or RK patients who had LASIK on top of it or some other surgery, are going dry. You should know how to correct the dryness, the tears. So I correct that with my proprietary moist therapy. No matter what your doctor uses, I have no problem with them using their own techniques, but it needs to be addressed. So now let's summarize what skills are needed. The tear film management or the dry eye management, very important. The corneal level of skills, the laser on the cornea, lamellar graft, DSEC, DMEC surgery for Fuchs, all right, scar surgeries in the cornea. Lens-based cataract surgery, lens exchange surgery, piggyback lens surgery, high toric lens surgery, very important. Many doctors are using the light adjustable lens in these cases or the Aptera IC8 lenses. That's fine. But understand, just going on and on, adjusting the lens over here 3 times, 4 times, does not make sense. You have another factor that's affecting you, the cornea. So many of these patients fly to me disheartened that their doctor did 4, what I call it, lockings and all that. Again, okay. But they have not addressed the cornea, the windshield, which is broken permanently. So there has to be a holistic way of correcting RKIs, from the tears to the cornea to the lens, and in either direction. You can combine techniques in a patient. I would do a cataract surgery, come back and do laser plastic for scars on the RK. I call that inside-out technique. In cases the cornea is completely aberrated, completely scarred, I first fix the cornea with whatever technique, as I just mentioned to you. Then go inside the eye and do the intelligent lensoplastic-based cataract surgery. There's no need to cross-link RK corneas because most of you are old enough that your corneas are not changing other than fluctuating. Very rarely do you need cross-linking. The most common reason for fluctuation in my experience is a bad tear film, because remember your windshield goes dry. When the wiper goes across, you see clearly. Second, your numbers, meaning you're so optically far away with your glasses number that your pendulum moves a lot. When you bring you closer to zero, you start not noticing the fluctuation so much. The last thing you ever need is crossing in. Very rarely have I ever had to use it in my 3 decades. Not needed for RK corneas. Fix the cornea. Then I also do other things like I'm driven for vision. So most of our patients do fantastic, even though, again, remember, please, there are no guarantees for anyone. In our practice, at least, we do not advertise, do not schmooze with anyone. There is nothing going on. It's just performance. So for me, my passion is making sure I've designed the right surgery. Some patients have planned stages. Just because of how flat their cornea has become, I'll just exaggerate for you. This is normal cornea. Let's say you become flat from RK, and this is your center, flat. What I will do then is I'll do lensoplastic in such a way that I will induce an optical change that will allow me to then come back with the laser and steepen your cornea, make it more normal. So there's your night vision, reading vision, everything back. Similarly, I will play with the cornea if I'm doing outside in technique, and then come and slam the vision, straight dunk it with the lens-based technique. So there is no limits, but all of these require surgical skills at all the levels. You cannot leave the patient half done or abandoned or do something wrong when you're already in such a difficult spot with your previous radial keratotomy, right? So, and even if you had bad surgeries, you had a light adjustable lens or any lens put in, don't worry, it can be fixed. If you had a bad corneal, you had LASIK on top, or someone did some laser surgery or something, it's okay. It just makes my work a little more difficult, but please don't lose hope. You can be helped. So I hope this helps you understand that dedication for radial keratotomy patients is a must to begin helping y'all. Absolutely. 3 decades I've been fighting for y'all, and there is absolutely no advertising here, no schmoozing with anyone. Only if you understand these concepts, I'm ready to fight for y'all. And please spread the knowledge. I'm trying my best to teach surgeons all over the planet. Been writing, been speaking, been teaching, been talking for 3 decades through our patients' eyes. Go to our YouTube channel, Gulani Vision, and you'll be amazed. We have recorded our patients from the minute they fly in, through their surgery, through their immediate post-op. They're flying back for their other eye, again through their surgeries, through their post-ops. For you, there is no such thing as extremely complex. Yes, you all are difficult. Yes, you all are type A personalities. I call you lions, remember, stuck in a cage. But it's the doctor's duty to fight for you all. So, any questions, you know where to find me, GulaniVision.com. And for your eyes, always, Dr. Gulani.